largest HIV outbreak in Indiana. This is a map that's currently on our website of 2014. It's our spotlight map that typically identifies the counties and what their annual HIV rates are going, like the new annual rates going on in that county. And this comes out every single year, and it's released to the public after the data has been cleaned and submitted to CDC. So this is posted, like I said, on our website, and it's on the later slides if you want to check it out on your own. And it is later on in the presentation. And I did want to kind of go into a little bit about what I thought you might be interested in. So I pulled up two specific areas. Obviously, I pulled up Allen County because that's where we're at today. And then I also pulled up the area where the outbreak is currently being investigated at. So each county is very different, and you can kind of tell that just from looking at the surrounding counties and what's reported. And Dan Hillman, who's our HIV epidemiologist at the state, he's the one who compiles all of this data and is releasing it every single year. And he's the person who can assist any counties in analyzing their data and determining what is to be expected for each county every year. And so when you look at Allen County, according to the map, there were 19 new cases of HIV reported, and then 583 cases currently living in Allen County at the time. And these, like I said, are released every single year, and I did provide the link. And then looking at Scott County, additionally, they only had less than 5 new cases each year and only had 21 living in Scott County at the time. And so, again, if anyone has any specific questions about the data that's released, Dan Hillman is the man that you want to talk to, and he's helpful and happy to analyze it and review it and make sure that counties are getting exactly the information that they need. And then the big question, as I'm always asked, is what is an outbreak? So according to our Communicable Disease Reporting Code, it's defined as any type, means cases of a disease occurring in a community, region, or particular population at a rate in excess than normally expected. It's kind of flexible, but this applies to any communicable disease, not just HIV. So when we identified the cases being labeled as an outbreak, we had a very large response that we had to come up with. And our response typically included policy change on naloxone and needle exchange programs. We had a community outreach center called the COC, and that was a combination of federal, state, and community partners working together to make sure services were provided. In addition, we also had a very strong public health infrastructure comprised of disease intervention specialists, care coordinators, surveillance, and data compilation. And we wanted to find a way to provide more resources to the rural community. In addition, we also had CDC assistance. We were able to request epi-aides and disease intervention specialists from across the U.S. to come assist with contact tracing. So this is a photo of the Community Outreach Center that I took from my car one day. I thought it was a really good representation of what was going on. And essentially, half of it was a one-stop shop, meaning that there was services like BMV, birth certificates, all housed in one area, and care coordination. So you could go in, you could get tested, and if you did test positive, there were a bunch of resources for you immediately. And then on the other side, which is towards the back, that wasn't represented in this photo, was where the needle exchange was taking place. And I'm going to go into a little bit more detail. So in addition, we had a very complex incident command structure at ISDH. Because this was such a multifaceted problem, we had to approach it in different ways. It was very important that we provided many different services, like I said, BMV, birth certificate, immunizations, specifically with Hep A and B, and we also provided substance abuse services with LifeSprings, and we also had care coordinators travel to be there on site. And this is a continuation of more of our command structure. And then as of yesterday, there were 175 total confirmed cases linked to the outbreak. So for those of you who don't know, HIV has 2 tests run, and that's a screening and a confirmatory test. And so when we say preliminary positives, we're talking they've only had a screening test, and then a confirmed positive is they've had both screening and confirmed positive. A little bit of information about those who are at risk for this in Scott County. It included people who injected Opana. Typically, this was multi-generational and between family and friends. So we saw grandparents and sharing with their children or their grandchildren and with friends and family. It was very structured within the community. In addition, we also had commercial sex work for those who were at risk, and we also had little to no employment for those who were testing positive and even high-risk negatives. And then a lot of individuals identified recent incarceration, whether that was local jails or even in prisons. And then as well as we had very limited substance abuse resources at the time, and in addition, 92% were co-infected with hepatitis C, which is a very significant number. So in order to publish information and give an update of this situation, we wrote an MMWR that was published on May 1st that kind of gave a little bit of a situation overview of what was exactly going on. And then another question I get, and maybe most of you guys already know this, is what happens when someone tests positive for HIV? What's typically the response? So when a patient goes to a provider's office and they test positive, the reports are supposed to go to the Indiana State Department of Health within 72 hours. And the reason why we do this is so that a patient can be contacted by a disease intervention specialist, and those contacts that they have are tested, and the patient will be referred to care immediately. And then when the patient is enrolled in care, and they also will go see an infectious disease doctor, they will also be prescribed antiretroviral therapy. The other big question after that is, well, who's responsible for reporting this information? There's a lot of different ball players, but all of them report different things. So it is imperative that all three of these entities, hospitals, laboratories, and clinicians, report because they each provide different information about the case. And if anyone has any questions about reporting, I do have some information from our surveillance coordinator with me, so you could always stop me afterwards and I could give you the information that you need. And a lot of times, individuals don't really realize that this is actually in our reporting code. So per Indiana State Code, it is required that a disease intervention specialist will investigate and contact trace anyone within 72 hours of their HIV diagnosis. And I've been talking a lot about DIS, and I know that we've got some in the room. So I'm a former DIS, and when I say that, I mean disease intervention specialists, and they have a ton of responsibility. They're the ones who are critical to public health investigations. They can be used in other areas, not just in HIV or STDs, but typically they're responsible for case management, partner services, and education. And this can include anything from STDs, helping someone get treatment, to contact tracing, to even helping refer patients into care and get them where they need. I know that DIS have been used all over the US. One example that I'm really fond of is there was a bridge collapse in Minnesota, and they actually called upon DIS to come help do contact tracing. And with that said, we have roughly about 22 DIS, give or take, around the state, and they're all housed in different areas. Like I said, I'm from District 7 and District 5, technically. But my hometown's Fort Wayne, so I'm happy to be here. And we have 10 DIS districts throughout the state. So who are our local disease intervention specialists? Well, we've got Kathy Thornson, who's our HIV STD Division Director, and I know she's here today because I've seen her. And then in addition, we also have disease intervention specialists who are our boots on the ground. We've got Corinne Taylor, Pamela Cashdollar, and Rochelle Fieldheiser-Keys. And it's very important that if you haven't met them already, that you kind of make that contact with them because they can be very helpful in situations not only with HIV, but also STDs. They are a wealth of knowledge and very good at what they do. In addition, we also have care coordination. So in the state of Indiana, after a patient tests positive for HIV, they're referred to local care coordination sites and an infectious disease doctor that's local to the patient if they prefer. So the care coordination sites will provide the client with access to medication and insurance, financial assistance, housing assistance, really whatever social services that they may need. And in addition, the infectious disease doctor is going to help with antiretroviral therapy and reducing that viral load to help prevent transmission in the future as well. In the state of Indiana, we have 16 care coordination sites statewide and 5 satellite offices. So there are care coordination sites available throughout the state whether you're local or rural or urban settings. And in Indiana, our goal is to get people in care coordination within 48 hours of their diagnosis. And these obviously are key resources for those who do test positive for HIV. So in addition, after someone tests positive, there's kind of like a 3-step process of what happens. So the patient's going to be enrolled in services, they're going to be assigned a care coordinator, and they're going to monitor their follow-up. And the patient's also going to enroll in some form of health insurance if they don't already have one. Then they're going to talk with an infectious disease doctor. They're going to start on antiretroviral therapy, hopefully as soon as possible. And that lab work is going to be done to monitor the CD4 and viral loads. And then the patient will be tested annually for STDs. And then in addition, we're going to hopefully get that patient to continue care. And we want that person to remain in care with care coordination for as long as they need those services. And hopefully they will continue to see their infectious disease doctor even if care coordination no longer applies to them. So in addition to our awesome disease intervention specialists, I had a list compiled of our local care coordination resources here in Allen County. And I believe this now at the Positive Resource Center. I used to know them as AIDS Task Force, but I'm pretty sure they changed their name on me. And again, if you haven't met them yet, it's very important to reach out and make contact because they also are a wealth of knowledge. And they have a very hard job at keeping those who are in positive in care. Do you have a question? For care coordination? For the disease intervention specialists or care coordinators? Oh, I believe that they are multi-area. Like I think they have multiple areas that they serve. Kathy, if you could help me out here. And if you'd like, I can get you their contact map as well. So thinking about the future of Scott County, what's lies ahead for the future, right? So the most important thing for those who are positive, it's important for them to not only enroll in care, but stay in care. It's also extremely important to test all women who are HIV positive for pregnancy, hepatitis, and syphilis. And it's very essential that patients who are enrolled in care and they work with an ID doctor that they also continue to comply with their ART medications because we want to lower that viral load and help reduce transmission. In addition, we really want to recommend that the physicians in that area start using PrEP based on CDC's best practices for men and women who are at elevated risk for HIV. And that includes partners, needle-sharing partners, or sex partners. Really, there should be a different combination for those individuals to start PrEP. Yes, we had another question. Oh, okay. So I think you're asking what age range are we seeing typically? Definitely. Well, for STDs, I know that they primarily affect those between 15 and 24. That's typically the age range we see for people testing positive for STDs, so the younger generations. And then as for the outbreak response, it ranged in from anyone from 18 to, I want to say, mid-50s. I don't have the exact numbers off the top of my head, but it was really a multi-generational thing, so it really wasn't a specific age group. Does that make sense? Okay. So in addition, what else can be done? There's more than just testing people, and there's more than just prescribing PrEP. What we have done at ISDH is we created a You Are Not Alone campaign, and we have these billboards posted all over southern Indiana to really hit home that it's really not just a county problem. This is a statewide problem. This is an Indiana campaign, and we are hoping to, as a united front, test people and make sure that they know that they are not alone. In addition, prevention is key. So you can't just test someone once for HIV and think that that means that they're negative. Unfortunately, with HIV specifically, there's an incubation period of up to 3 months if you're using the oral test, where it may or may not pick up that infection. So it's really important to retest patients who may be at risk for HIV. In addition, awareness of STDs and HIV is critical as well. We want to make sure that patients know about HIV and understand what it really truly means to be at risk. In addition, we also wanted to notify counties of our syringe exchange or access program, and we've provided guidance on our website on how that would be started and how you would identify that. In addition, we created county profiles, which I've listed the website here. Oh, I think I might have skipped one. So on June 6th, we compiled data for all local health departments into county profiles, which were giving guidance on the new syringe access law. And we tried to include key information that could help different counties identify and analyze if they wanted to work with and have a needle exchange program in their county. And the data that we provided was STD and HIV data, Hep C, substance abuse, and ER visits due to opioids. And if any county is interested in looking further into this, like I said, Dan Hellman would be the person who would help analyze that. And any additional requests on HIV or Hep C data can be given to the local health department info website, and then they can actually work with a group to help analyze the data and gather any additional resources that you may need. So I just pulled the county profile for Allen County off of the website, and ISDH, like I said, has an EPI team available that would work through this data to really explain it and walk through it with any locals that are interested in working with a needle exchange program. So in addition, lessons learned. So we did a lot of response for this outbreak, and so there was a lot of information to learn about it. The first thing that is very near and dear to my heart is disease intervention specialists are crucial to public health. Without the efforts of our disease intervention specialists down south, we would have never been able to identify this outbreak as quickly as we did. Because of the quick local response in identifying and testing those contacts, that's how we were able to identify that this was a major situation that needed further action. In addition, we also talked about the testing technology a lot during the outbreak. So a lot of times we have oral tests out of convenience. It's really helpful to be in the field or to be at someone's home and be able to do an oral swab for HIV. But we found that because of acute cases, it's more important to switch to a blood test, specifically NAT testing technology, which I'm going to go over in a few minutes. And we found that a lot of the blood tests were extremely accurate in picking up very acute infections. In addition, we also found that retesting was essential, especially for those who were at risk for acute infections. And then, of course, surveillance is key. Without the help of the data compiled and our disease intervention specialists and a team effort, we would not have been nearly as successful in identifying that this was a major and critical outbreak. So in addition to NAT testing, that's a blood test that can detect up to 10 days after exposure, which is really, that's incredible. Specifically when our other blood tests, our multi-spot can take up to 30 days, and our oral and Western blots are a little bit longer than that. So you can kind of see on this chart that it really just depends on the type of testing technology that you use and when the patient's most recent exposure was. In addition, we also found that it was extremely important to get people into care as soon as possible if they were ready. Of course, this depends on the person, and if not everyone's ready to get into care within 48 hours, you have to really work with that individual to make sure you're following up and that they are going into care as soon as they're ready to do so. In addition, we also found that ART and viral suppression goals, we had to have them established, meaning that we needed to know what we were shooting for. Did we want everyone to be at 100% viral suppression within a day? That wasn't really realistic. So we really needed to know what to shoot for, and this is something that we're still working on to this day. In addition, we found that it is extremely important to test positive women for HIV, to also test them for pregnancy, because we really want those moms to get into care as early as possible to help reduce that viral load, to reduce the possible transmission to the fetus. In addition, we also found that it was very important for our incident command response to be a unified response. So we worked with federal, local, and state resources, and we quickly identified a plan of action. And ideally, we would want to do this before another outbreak. So for other counties, it's recommended that we start working now. Start working with your locals, start working with your disease intervention specialists, your care coordinators to develop a good plan of action prior to any issue coming up. And in addition, we learned how important it was to keep the local health officers up to speed on the data of their county. And that's why we created those county profiles, so that they could look at that data and also determine what was best for their area. Since every county is so different, it was important that each individual county was able to get that information and work with ISDH on analyzing it. So we also identified that it was crucial to keep local resources informed during the outbreak, and we did that through teleconferences, but we also did it in other ways, like on the phone. We tried to go down there as often as we could, like I was down there probably every other week for a while. So it was really important that the local resources and the state resources and CDC were a unified response and all in communication about what was going on. In addition, it was important to have DIS and care coordination working very closely together. So we found it was extremely helpful that in Clark County Health Department, they house the disease intervention specialists and the care coordination on site together, which is kind of specific to that area, but we found that it was very helpful that they were housed under the same roof. So once they were diagnosed, they could immediately go get enrolled with care coordination. And I know that that's not always possible depending on the areas, but we did find that it was an area that was extremely helpful. In addition, we were very passionate about getting a CDC DIS team response for the outbreak. So we were able to work with EMAC and request DIS from other areas to come in and assist with contact tracing because we were looking for so many contacts. It was very helpful to have 8 to 10 DIS to go out in pairs and work together and try to get as many people tested as possible. And I know that's not always possible in the local areas, but it was something that we found was very helpful. In addition, it was very important that we had packets for people who were not RDIS so that they were able to quickly deploy. In addition, it was very, very important at the Community Outreach Center that it was completely separate, the needle exchange was completely separate from the other resources because confidentiality is imperative, especially to that population. It was very important to build rapport and gain trust in the community. So in order for us to do that, we kept the services separate from the needle exchange. In addition, we also found that phylogenetic testing of all the blood samples was very important in identifying that this was an acute case. We were able to do this for both HIV and hepatitis C, and it allowed us to identify if this was the same strain or if it was separate strains throughout a community. And during an outbreak response, it's very important to know the whole picture. And then, of course, hepatitis testing, like I said, 92% were co-infected with hepatitis C. So it was very important that we provided hepatitis testing for A, B, and C. And also, I think we had the twin Rix vaccine available for those who were testing negative. And most people down there didn't know that they were either confirmed positive for hep C. Many of them just said, I'm sure I've got it, or I definitely probably have it because I've shared so often. So it was important to give them testing for that so that they were able to know and make that distinguishation for when they go to their physicians. And then in addition, it was very important that we had a very strong response with our public affairs office, and they were able to help the local health officers and help them with all of the media surrounding this so that we were able to come up with a very strong response and help local leadership and state work together as a team to help combat what was going on. There was a lot of lessons learned, as you can tell. Essentially, it was also very important that we had data available. We wanted to make sure that the CDC and state were working together to have an epi team, what we called it, available so that we were able to provide more information to our boots on the ground. In addition, it was very important that we looked at the communicable disease reporting law for public health and really stressed the importance of reporting in a timely manner. If we hadn't identified this outbreak so quickly through reporting, it would have been a lot worse on identifying those contacts and potentially might have spread the virus further. And that's why I said earlier it's important that all those key ball players are reporting. That includes hospitals, labs, and physicians. And of course, STD and hepatitis C prevention is HIV prevention. So if there is a patient who tests positive for an STD or Hep C on their own, it's very important to also provide HIV testing as well, since co-infection can be such a strong prevalence, specifically in that area as well. And I know I've said this repeatedly, but it's extremely important to know your local resources early. That also includes not just DIS and care coordination, but it includes substance abuse resources, mental health and counseling, and of course Medicaid and HIP 2.0 enrollment services. So it's important for all of the key players to know each other and be able to make quick contact. In addition, it was very important for ISTH to let other surrounding states know what was going on, specifically because we have a very transient population, specifically among injection drug users in that area. So people are often moving around, couch surfing, going to other states, coming back. So it was important for us to make contact with Kentucky and Ohio and other surrounding states to let them know what was going on in case they needed to up their surveillance services as well. And of course, I work in the STD prevention program, but I'm part of the HIV, STD, and viral hepatitis division. And so we all work together to compile complete services for the whole state. And I wanted to make sure that everyone had contact information for the different services. So for HIV prevention, the manager of that is Satin Francis. And additionally, like I've mentioned his name a million times before, Dan Hillman is our HIV surveillance epidemiologist. He's able to help with analyzing any data questions and help counties and locals identify what's normal and what's abnormal for their area. In addition, we also have Jen Myers. She's the Ryan White Part B director. She's able to help with care coordination services and help identify what's most important. And we also have, in the STD division, Jeremy Roseberry, who's the interim manager at this time. And additionally, in hepatitis C, Lynetta Alexander and Brittany Gross. If there's any data questions about Hep C that we can help answer, Lynetta Alexander and Brittany Gross can definitely help analyze that data and get you more if needed. In addition, there's Sue Henry, who's the chief nursing consultant in Hep B. And of course, the HIV, STD, viral hepatitis division director is Andrea Perez. And our state epidemiologist, Pam Pontonis, was another key player in helping us with this outbreak. And our chief medical officer is Dr. Duvey. And we all have our emails on here. I don't think mine's on here, but if you had any questions, any of these individuals would be more than happy to assist. And I just wanted to list a few references that I had, but are there any questions that I can answer? Kind of threw a lot. Yes. The total cost of this, I don't even think we've had time to compile all of the different costs, but I know that it will, I'm definitely certain it's going to be within the next probably few months that we'll be able to compile all of it. But I'm sure, as you know, like the response hasn't quite stopped yet. We're still helping local resources as much as we can, but that is a great question. Yes. Can you ask that one more time? You mean with total care? I don't have that number off the top of my head, but I know it's going to be a significant number, especially because I know in Scott County we've had 175 tests positive, but that's in addition to however many in the other surrounding areas also test positive, just on a normal basis for HIV. So that's a great question, and I will definitely try to get an answer for you, but I don't have it off the top of my head. Sorry, I missed that question too. What was that? Right, that's a great question, and why prevention is so important. Obviously, cost is a huge issue, and it's not just prevention, it's education, right? We want to make sure that the people who are testing positive know how to prevent transmission, and if they don't understand how to do that, then we're just going to have more transmission. So you're totally spot on in thinking about the future and costs in medical care, and that's a great question, and that's something that I think Indiana is going to have to work with, specifically Jen Myers, on getting Ryan White funding and looking for other grants that might be available so we can assist further. Yes. That is a wonderful question, and we are still working on trying to get that data. The question was, how many of those who tested positive went on to receive substance abuse services? I know that working with the disease intervention specialists that they were all referred to substance abuse services, but many of the individuals who tested positive they weren't ready for it. We'll put it that way. They needed more time. They needed to identify what was best for them and their families. So we're still trying to identify the exact number of those who tested positive and they went into substance abuse services, because like I said, we know they were all referred there, but whether or not they took on that is a whole nother issue, because I know that many of the substance abuse centers can't disclose whether or not someone actually enrolled in care. So that's something we're still trying to figure out. Yes.
Turn it on. Thank you. Magic. I just want to because I think this is important. She raised the issue of how important prevention is, and I want to let you know that a group of people here in Allen County are working on how do we prevent such a outbreak here in our community, because we do have a huge heroin usage problem here, and they aren't using Opana, which is a prescription drug, but folks here are using heroin. And so probably about 6 weeks ago, we got a group of people together to kind of talk about this issue and talk about different ways that we could actually help mitigate that problem here in Allen County. And I just want to introduce a few people, and if you're interested on serving on that task force, just talk with these folks. Kathy and I are doing the Needle Exchange Program along with Mindy Waldron. Raise your hands. We're doing the Needle Exchange Program. We've already got pretty good start on that, on what that would look like here if we were ever had the epidemiology numbers to support actually the state health commissioner telling us to launch one. We would be, hopefully in the next month or so, we'll be ready to go on that. So there's a group doing that. Megan is heading a group of folks, you want to raise your hand, is heading a group of folks that really looking at prevention, is really looking how do we educate folks on young people on heroin and other types of prescription drugs that are really dangerous for them. So they're going through all of the materials that kids are getting in school to make sure that, I mean, obviously whatever we're doing isn't enough. The biggest group is 18 to 25-year-olds that are actually using heroin. So what are we teaching them? Whatever we're doing right now isn't working, so we need to look and see, do we need more of the same? Do we need to start earlier? Do we need new materials? So she's heading up that group.